A 29-year-old woman comes to the emergency department with 2 days of fever, chills, and left-sided flank pain. She also reports painful urination and dark-colored urine for the past 3 days. Ibuprofen use only provided partial relief. She has no significant past medical history and is sexually active with one partner. Physical examination shows a temperature of 38.9 degrees Celsius, 102 degrees Fahrenheit. Blood pressure is 112/70 millimeters mercury, and heart rate is 110 per minute. Laboratory studies show urine, leukocyte esterase positive, nitrites positive, RBCs 20 to 30 per high-powered field, WBCs are more than 50 per high-powered field, WBC casts are present, and serum creatinine is 1.0 milligrams per deciliter. Which of the following best describes this patient's condition? Choice A, cystitis. Choice B, pyelonephritis. Choice C, nephrolithiasis. Choice D, acute interstitial nephritis. Or choice E, acute tubular necrosis. I'll wait 5 seconds and answer a question. So this patient has fever, chills, tachycardia, and flank pain alongside painful urination. So this is all red flags for a UTI, right? And the urinalysis here shows leukocyte esterase, nitrites, WBCs. Obviously, all of these are all suggestive of an infectious etiology. You do have positive blood in the urine, RBCs 20 to 30. Obviously, if you have an inflammation of the kidneys, you can have hematuria. But if we look at the answer choices here, you can see that a lot of them can have infectious etiologies. So the big thing you want to look at here is the WBC CAS, right? That is highly suggestive and largely specific to pyelonephritis. Choice B is the correct answer. Now, I know a couple of you might be confused here because of choice D especially, but let's just go one by one and we'll look at the wrong answer choices here. Choice A, cystitis. I mean, this is the easiest one to rule out, right? Obviously, cystitis, even if it's infectious, you'd have dysuria, maybe you would have a fever, but of course, an infection limited to the bladder generally wouldn't cause flank pain or WBC CAS because WBC CAS are formed in the renal tubules. So just easy to rule out of all of these. Choice C, nephrolithiasis. So nephrolithiasis by itself can cause flank pain and hematuria, of course. You have all this other stuff here suggesting infectious etiology, WBC CAS, nitrites. So you might be thinking, well, couldn't we have an infection on top of nephrolithiasis? First point I want to make is that you really don't want to make that assumption unless you have no other choice. And the other thing is that WBC CAS tend to be formed in the renal tubules specifically, and nephrolithiasis tends to occur in the collecting ducts, like the renal pelvis, calyces, and the ureter as well. So they technically don't involve the renal tubules themselves a lot of time. So in a typical case of nephrolithiasis, you would not see WBC CAS. And this brings us to the choice D here as well. So acute interstitial nephritis, many of you probably have memorized that this is resulting from drug use such as NSAIDs and beta-lactams, and one of the most buzzy findings you'll find is WBCs in the urine, especially eosinophils. If you see eosinophils in the urine, that's almost beating you over head with the possibility of AIN. But once again, WBC CAS tend to form in the renal tubules. So WBC CAS are very atypical for AIN. Because in AIN, if you look at the name, acute interstitial nephritis, the inflammation is happening in the interstitium, not the tubules themselves. So WBC CAS actually don't form that often in AIN. Now, on step exam, when they give you WBC CAS, that's usually pretty heavily suggestive of pyelonephritis. Now, there's quite a few resources out there that will tell you that AIN can also cause WBC CAS, and they are correct to tell you that. If you go look at, retrospective studies and all that, something like, I think 20% of AIN cases do have WBC CAS. So I'm drawing a distinction here between the clinical reality and what you're going to see on step exam. So on step exam, WBC CAS, it's almost always going to be pyelo. In real life, yes, you can see WBC CAS in AIN. So of course, if I didn't have the answer choice pyelonephritis here, I would probably pick acute interstitial nephritis. But otherwise, you should pick pyelo. Choice E, acute tubular necrosis. This of course results from ischemia or renal toxicity, especially some kind of acute ischemia, because the PCT is highly sensitive to hypoxic injury due to the high amount of ATPase pumps in that region of the kidney. And acute tubular necrosis, of course, the most buzzy finding is the muddy brown granular CAS. Now, the way USMLE tends to really like testing this is that they'll give you some kind of vascular problem usually. So you can have an infarction somewhere, or you might even have a heart attack, or an arrhythmia like a AFib that might incidentally throw a clot and might reach the renal arteries. The point is that if I have any kind of thing that will acutely cut the blood supply to my kidneys, I'm at risk of developing ATN probably like a day later or something, because a lot of the proximal tubule has died off. That's basically what's happening. They like testing it that way. And I believe there have been questions in the past where they just straight up ask you which part of the kidney is most susceptible to hypoxic injury, and you're going to pick proximal convoluted tubule. So bring it back. I mean, this is actually not that hard of a question, right? Pyelonephritis with the flank pain and fever, and especially WBC casts, all very telling. Just be careful also the nitpicky stuff you might run into once in a while. I hope you found this video helpful. I'll see you in the next one.